Okay. I see. Good evening, friends. So, first of its kind of our sessions where we discuss cases. I am talking of 4 cases. One went on for a long time, and others were short time, but each left some message in the mind which one is not likely to forget ever. Those of you who are regular will see that there used to be a logo of Inches Academy, which is replaced by Amara Health. I have been talking a lot last maybe a year or so that we are launching an app and we are doing a lot of other activities. So this is a new company, Amara Health, by me, and all the future activities of continuing medical education through website, through offline seminars, face-to-face, and webinars will be done through Amara Health only. Case 1. A patient had undergone Roux-en via gastric bypass, that is a type of bariatric surgery. Patient presented with pain in the epigastric region and the left upper quadrant or left hypochondrium. Why I have started with this history is because the problem was related to that, and 8 years the patient had no complications. Pain was 5 on a scale of 1 to 10, exacerbated by eating. I think all of us, those who are not using, should always use a scale of pain. Every patient, whatever level of intelligence is able to understand, on a scale of 0 to 10, when 10 is the worst pain you've experienced in your life, at what level is your pain? Because when we ask people, pain is a subjective feeling. Mild, moderate, severe patient doesn't understand. So when you give this scale and the patient says 9 or 10 with a smile, then you understand that time only that it has a functional background. No melena or no fresh blood per rectum. Abdominal tenderness plus, but no rebound pain or guarding. So history of burps and incomplete evacuation despite multiple bowel movements. Past history, morbidly obese patient since childhood, was a smoker. His BMI at the age of 41 was 49 BMI. He quit smoking before bariatric and underwent bariatric surgery. He had history of dyslipidemia and was on rosuvastatin and ezetimibe. In the first year after surgery, he lost more than 80% of his excess weight. Total weight declining from 80 to 83, from 143 to 83.9. I know all this because the patient was my patient for the last 15 years. After the first post-operative year, the patient had some weight gain, which again depressed him and prompted him smoke again. This is one of the common things in bariatric surgery patients. After few years, this patient started in 1 year only, but after maybe 4 or 5 years, they all start gaining weight. His weight at this time when he came with pain was 95.3. Symptomatic treatment initially I gave was proton pump inhibitor. I gave rabeprazole, I gave domperidone, I gave rotavirine as and when required. Did not work. Basic workup was done because the pain was epigastrium and left upper quadrant, CBC, CRP, amylase, lipase. And because he was burping so much, we did LFT. They were all within normal limits or slight derangement which did not support the patient's symptoms. Ultrasound was not done because pancreas is generally not visible on ultrasound. And I have had some cases of complications of bariatric surgery, which were kind of a leak. But if there's a leak from the anastomosis, generally patient will have guarding. There was no guarding here, but I still advised a CT abdomen. Revealed no abnormality except inflammation of the gastrojejunal anastomosis. 8 years later, that anastomosis still showed inflammation. Was it old or was it fresh? But he had no complaints for last 8 years. On OGD scopy, an ulceration on the jejunal side of surgical anastomosis was identified. There was a suture material there. Non-absorbable suture material was irritating. That was removed because the gastroenterologist thought that may be irritating the mucosa and causing the inflammation. This is a picture of the ulceration. Symptomatic treatment again, because there was an ulceration at the anastomosis. Sorry, this is the same thing that I am showing you. Sorry. Patient treated with 40 milligram omeprazole OD with sucralfate 1 gram per 10 ml QDS for almost 6 weeks and a rigid diet control. Despite excellent adherence to the regimen and the diet, abdominal pain did not reduce. Serial repeat endoscopies conducted at 2-month interval revealed that ulcer was persistent. I was fortunate that patient did not leave me because I was always constantly interacting with the gastroenterologist. And every time the patient would come to me, I would talk to the gastroenterologist and take inputs. Within 6 months after diagnosis of the ulceration, 3 endoscopies done in between, the patient suddenly began to have foul-smelling, watery diarrhea 6 to 7 times a day with no diarrhea at night. These episodes were more voluminous after meals and often as visible particulate matter consistent with what he had recently eaten. So if he has taken lady's finger, he will say, doctor, in 45 minutes, I can see seeds of lady's finger in my stools. Even with a very massive intestinal hurry, such a thing is not explained. There were no specific dietary triggers. He was following a very controlled diet. Diarrhea associated with mild urgency, but no tenesmus or no incontinence. Stool was pale and there was no melena. Stool test did not show any occult blood. Patient also noticed an increase in the flatus he was passing and the feces smelling eructation. When he was getting burps, they were smelling like feces. 4 months, this patient had the same problem. Culture of the stools was done. We shifted different gastroenterologists. He was given at different times ofloxacin, cefixime, amikacin, metronidazole, IV fluids. Patient generalized weakness continued and he was having severe myalgias and muscle cramps also developed. His weight decreased from 95.3 to 72.6. This was 6 months' time. One night, he was feeling very faint. He said he thought he'll almost faint, so he went to casualty of a tertiary care. The patient was not staying in my area. Earlier on, he had stayed with me, but now he had shifted to a different place around 10 kilometers away. This tertiary care center had a very good casualty. Vital parameters normal. Appeared cachectic, but was not in acute distress. The doctor spoke to me from there. They said, have they ruled out malignancy? I said, yes. 2 biopsies have been done and there is no malignancy sign, at least from the ulcer. And CT scan has not shown anything. General systemic examination not contributory. Signs of weight loss, skin hanging on abdomen, skin turgor lost, and muscle wasting. CBC within normal limits. Renal function test within normal limits. LFT within normal limits. Potassium was low, hypokalemia 2.2 mg/%. Sodium and chloride were normal. Phosphorus was low, 1.5 milligram, normal being 2.4 to 4.3. Magnesium 1.6, normal being 1.7 to 2.6. Albumin 1.5 mg/%, normal being 3.5 to 5.4. CRP was 13.4. Normal, everybody knows, is 0 to 5. HIV was suspected because despite he having no clandestine relation, but HIV was negative. Our patient was admitted for monitoring, hydration, electrolyte supplementation, and further diagnosis, because this time, since he was there, we didn't want, he was earlier admitted 5 days for giving amikacin metronidazole, but this time we didn't want him to come out till we had a diagnosis. Stool routine and culture again were negative for bacterial infection or for ova or parasites. Colonoscopy revealed a small area of erythema near the hepatic flexure. The pain was in the left hypochondrium. Colonoscopy revealed the erythema near the hepatic flexure and no other abnormalities. Biopsy from colon and terminal ileum were normal. Ultra upper GI endoscopy revealed normal esophageal mucosa, marginal ulceration, and severe inflammation at the gastrojejunal inflammation, which was mild initially, now had become severe despite removing that suspect suture material. During endoscopy, when pressure was exerted on one of the areas of inflammation, the endoscope passed through a fistulous tract terminating in the transverse colon. This accidental diagnosis of fistula gave all the answers why soon after meal he was having voluminous diarrhea, why they could see undigested particles within 30 to 45 minutes of a meal, because right from jejunum, the food material was passing into the transverse colon and going out. Why voluminous? Because there was no absorption of water from the large intestine. Patient was given 2 months of total parenteral nutrition, nil by mouth for 2 months, and then endoscopic management of that fistula was done, and revision of the gastrojejunal anastomosis was done, and gastric pouch was done. After surgery, patient began to have normal stools, formed bowel movement, and transitioned back to oral nutrition. 6 months after surgery, patient is again 95.3. What is the take-home message? For an abdominal pelvic complaint, past surgical history is very, very, very important. Because, we ask for surgery. We do not ask where the surgery happened. Was it an emergency? Was it planned? Because most of the abdominopelvic surgeries, whatever duration, you should ask the history and you should ask any intervening complaints about the surgery. Keep in mind post-operative adhesions. Post-operative adhesions will cause intestinal obstruction. It may cause a fistula, as in this case, and it may cause a leakage of the anastomosis. Even if it was not bariatric, if it was even a colectomy or ileocolic anastomosis, from any anastomosis, after years, there could be leakage. I had a patient who in the month of October 22 underwent a surgery for intestinal obstruction because of previous adhesions. What previous adhesions? 32 years back, 32 years ago, cesarean section. And then after this surgery, within 5 months, she had another subacute obstruction, which could be managed conservatively. So any pain in the abdominopelvic area, and if there is a risk of, if there is a history of surgery done in past, please look out for complications of post-operative adhesions. Case 2, 66 male, new patient, came with a history of CKD in a case of hypertension, no diabetes, but not on dialysis, and he had good reports. Creatinine was around 3.9 milligram for at least last 1 year, with a 2-day history of left ring finger pain and bluish discoloration. Very faint blue, but you could make out that it is definitely bluish, because since he was CKD, he had anemia of chronic disease. But then you could make out that, yes, it could be, you may say, okay, not blue, but dusky. No history of any fever, injury, or other complaint of fingers since last 7 days. Vital parameters within normal limits. Local examination normal, except for discoloration on his finger, and finger was cool to touch as compared to the neighboring fingers. Felt with back of the hand and not by the palmar aspect of the finger. No swelling also. You could see all the creases of the finger very well. CBC done 1 week back showed anemia of chronic kidney disease. That means hemoglobin was 9.5, but MCV, MCH, MCHC were all normal. So normocytic normochromic anemia is known as anemia of chronic disease. Very commonly in CKD, less commonly seen in cirrhosis of liver. He had already done an X-ray of the finger. He had spoken to his kidney doctor, who said, get an X-ray done on the finger because maybe there is a small injury and maybe some fracture has occurred. X-ray was normal. We repeated CBC, CRP. CBC within normal limits except anemia of chronic disease. CRP 9.4, not contributory. What are the thoughts in the mind? Infection, WBC was normal. There was no evidence of any paronychia or koilonychia or any abscess on the finger. So infection was ruled out. Rheumatoid, yes, single digit rheumatoid is known, but here onset was very rapid. Single digit, no visible involvement of MCP joint. Rheumatoid will definitely cause swelling of the metacarpophalangeal joint. more so in the index and the middle finger. But then that also was not there. Worst case scenario, we have to think where instant action may be required. Cool to touch and bluish discoloration support that there is lack of blood supply, ischemic finger. Now, ischemic finger, how do we confirm? If I send him for Doppler, I may not be able to pick up. If it is ischemia, it's like a TIA or a stroke in the brain. Blood is going less to a certain part of the body, in this, the finger. Do I do an angio? If I send him to tertiary care, they'll definitely do an angio. Do I do Doppler? Will I get the yield? I suddenly thought of SpO2. Because if it is ischemia, then definitely less blood is going. If less blood is going, then less oxygen is going. 78% in affected finger and 96% in adjoining two. He was referred to a vascular surgeon. They did a Doppler. The hospital had a very sophisticated machine. They found microemboli. ECG we did in the clinic, which shows atrial fibrillation, heart rate of 144. So now the theory of embolization due to atrial fibrillation was confirmed. Fortunately for the patient and for me, the embolization was not into a major artery. It was in a very tiny artery. He was treated as a microembolus, amiodarone and dabigatran. This been about 7 weeks. Treatment is still going on. The finger came back to normal in about 72 hours. Take home message, clinical thinking. We all have the expertise of thinking what is going on, but think what could be wrong. And I have, one thing has helped me in my practice, which was a piece of Gyan given by Dr. Amdekar. In 1995, I attended a seminar by him on fever in children. He said, every time you send a child out from your clinic, think, can this child die on me in next 24 hours? And I have adopted this line to every patient, adult, child, fever, chest pain, abdominal pain, or whatever. The question is, am I missing something that may cause irreversible damage in 24 hours or death? Case 3, 49 male. During a corporate check, PSA was 25.2 nanogram per ml. No family history in father or brothers of prostate cancer. Last year, PSA was 1.2. They do every year. Routine urine showed 20 to 25 pastilles per HPF. I have seen myself a PSA of even 40 with a patient in UTI coming down to normal after you treat UTI. So we weren't worried much. He had no urinary symptoms. Treated with nitrofurantoin 100 milligram BD for 10 days. Repeat routine urine after 15 days. 5-day gap after treatment was within normal limits. Instead of repeat PSA, I asked him to do free PSA and total PSA and the ratio. This is always my preference. We do health checkups in the clinic, but we never do PSA. We do always the free and total and ratio. Total PSA was 27.897. Free PSA was 1.440. The ratio was 5.16. And the rule is ratio below 25% favors cancer prostate. And a ratio above 25% favors benign prostatic hypertrophy. Why we do this always? Because in a patient who has BPH, many times you have raised PSA, but the ratio is about 25%. So this is a very important parameter for us to go very seriously into a patient's investigation if this ratio supports cancer prostate. Another patient, you see, total PSA was normal, free PSA was 0.79, ratio was 48. This favors BPH. So this patient of mine, we sent for an ultrasound, which showed that there is slight enlargement of the prostate, but no calcification, no irregularities. Sent to a neurosurgeon who on PR examination said he feels that the median lobe is enlarged and it is hard. Then he himself said, doctor, if it is malignancy, you should get it operated only in robotic surgery, not conventional. So we did an MRI, which confirmed that right lobe had some kind of a growth inside other than the normal prostatic tissue. Patient was referred to a tertiary care center where there is a robotic machine. They did a biopsy, which confirmed that the right lobe had malignancy, but it had still within the prostate, not spread outside. With my experience, I say that if one has to have a cancer male, then prostate is the best, because I had patients who have lived for 10, 20, 25 years after diagnosis and management. Of course, they were pre-robotic era. So this patient went to almost 6 different surgeons. All of them said surgery. Only one oncologist. You know, nowadays, there are very fancy names being attached to specialties. This person calls herself as focused oncologist. She said, we will give radiation and chemo. I told the patient, always go to a neurosurgeon. All 6 said surgery, and all were honest. 3 of them were not having hospitals where robotic was done. They said robotic is the must. Patients with BPH, prostatic symptoms above 50, of course this was 49, never ask PSA alone, ask free and total PSA with ratio. Look for a ratio above 25 or below 25. Follow up with ultrasound, preferably with a rectal probe. Refer to a urologist or an MRI. If you are more aggressive, you may do MRI before sending to a urologist. Surgery for prostatic cancer should be robotic only. You may wonder, what if my patient doesn't afford? See, every surgery has a cost. Robotic costs another 1.5 lakh rupees based on consumables. So there are certain states in life where we tell patient, beg, borrow, steal, but this surgery has to be done. I think prostate cancer, robotic is one such thing. Last case, very short case. 78 male, no diabetes, no hypertension, no other comorbidities, very healthy person. My patient, retired pilot, went to village, fell down, had fracture shaft of femur. He was suggested surgery, but family refused. So rest in bed for 3 months. On 14th post-trauma day, complained of severe shortness of breath. Dead on arrival when reached the hospital. Post-mortem done because patient has reached hospital dead. Otherwise, in village, somebody would have given a death certificate. Pulmonary embolism was the cause of death. Now, it is very well known that pulmonary embolism can occur in a long bone fracture of the lower limb or in a abdominopelvic surgery, major surgery. That is why in major cities, they always operate, and they operate as soon as possible. They mobilize as soon as possible. In less than 12 hours, they mobilize the patient. And wherever you give bed rest, for some reason, if you can't operate, you have to do DVT prophylaxis. DVT prophylaxis is same as pulmonary embolism prophylaxis, either medications or those stockings with pump so that the patient is protected. Please make sure that no patient of yours goes through prolonged bed rest, especially above 55-60. This is very common. The cause is fat embolism. Deep vein thrombosis and pulmonary embolism are known complications after trauma, and long extremity fractures, long bone, both bones are, all three are long, but femur and tibia with fibula, you may not get that much, which carry significant morbidity and mortality. The fat emboli from the bone marrow, it is not that only conservatively treated fractures, even operated fractures will get this. That is why immediate mobilization is required, and there is now a regime of giving anticoagulants, novel oral anticoagulants in every case of knee replacement and hip replacement for a certain period of time. So fat embolism, it's cause of fat embolism syndrome, FES. The early fixation of long bone fracture is important to prevent or decrease the incidence of FES. Otherwise, you may lose a patient not to the fracture, but to an embolism. It can occur in pulmonary embolism, it can occur in a cerebral, it could occur in a cardiac. These are 4 cases for today. I request anyone here who would like to discuss a case or what they have learned from their patients in practice. And if everybody likes this, maybe once a month we could do cases. I did only 4. I thought it will take time, but next time onwards we can prepare 7 and 8. And any one of you has reports of any patient, it need not be a very tricky case. It should be something that has taught us something which we, when you learn something on your own, you never forget in your life. So friends, see you next time with some topic. What is the benefit of robotic surgery? Robotic surgery is where the machine operates, the doctor conducts the thing. Minimum blood loss, minimum risk. Robotic prostate doesn't require blood transfusion. Minimum risk of urethra rupture. causing incontinence, minimal sexual dysfunction. And if there are mets, they can be dealt with in a very good way. How many days risk remains for embolism after fracture? It could happen for after a month also. But idea is that if you operate immediately, then you are mobilizing immediately, the risk goes down. And if you are putting in bed for a long time and you are using anti-clotting or like anticoagulation treatment, either pump or medicine, then you have to give it at least for 3 months, not less. Thank you. So we will, in first case, CT scan abdomen with oral contrast should have picked up the gastric colic fistula. Yes, retrospective, we feel it could have been, but then the fistula actually occurred when the diarrhea started. You know, we did a CT scan on day 4-5 of the presenting patient come to me. That time, if it was a fistula, the copious diarrhea would have begun that time only. And once the patient is having such copious diarrhea, generally radiologists will not be willing to do a oral contrast. I hope, Dr. Jayashree, you are satisfied. And most important is, one thing I will tell all of us. Many of us refer a patient and then forget about the patient. As a friend used to say, we are referring, we are not offering it to the consultant. Always remain involved. Otherwise, you won't even know where you lose your patients, who are anyway difficult to come by nowadays. Bye. Have a nice evening. So every month on 2nd, we will have cases. The rest of the day, we will have our other topics. Thank you.